COVID-19 ACC AHA guideline, and this is on the management of patients with atrial fibrillation. So, Jim comes to PAC for a TKR workup. He's 75 years old, known AF, surgery date not determined yet, no other past history, nil meds. Should he be on anticoagulants? Take 5 seconds.
So based on his CHA2DS2-VASc score, he only scored 1 for his age. As far as I can see.
I'm glad you invoked CHA2DS2-VASc because that's how they often determine whether they should be on it. I think because he's greater than 75 years of age, he gets 2 points.
Oh yeah, that's true. He gets 2 points. So yes, he should be on anticoagulation, and it can be either a DOAC or warfarin.
Beautiful. How would you decide between warfarin or a DOAC?
I think that there's new evidence based on that guideline that you would need to read, and patients who they have no contraindication to DOACs should have a DOAC as first line now. Yeah, fantastic. Hey, I just wanted to make particular mention of this guy, the CHA2DS2-VASc score. So just note that there seems to be 10 points that you can get, but you can actually only score 9. Why is that?
Can't be 2 ages at once.
Exactly. Your maximum score for age is that. Perfect. Just in case that was some kind of multi-choice in the future. Anyway, exactly. So for patients with AF, it doesn't really require much to have a recommendation for anticoagulation. A score of 2 for women, men, and 3 or greater for women. Oral anticoagulants are recommended. And as you mentioned rightly, according to the guidelines, pretty much anyone who's NOAC eligible or DOAC eligible should be on that. So Priya, who should be on warfarin then?
Patients in which you need to, I think it's related to like patients who really need tight control over the INR and to be guaranteed that you're anticoagulated with a monitor. So someone with like coexisting mitral valve disease or mitral valve related AF. Yeah,
sounds good. So the guideline mentions having moderate to severe mitral stenosis or mechanical heart valve. The mechanical heart valve is, obvious, but they also mean NOAC if it's unstable INRs. And renal impairment for some NOACs might be an indication for warfarin. So just to move on from that, again, that's not something I ever really think about, so I thought it's worthwhile for everyone to know that obviously there's a guideline for that, and it's a recent guideline as well, and again, helps you to really think about your patients as they come in. Most of them are on these and they're already well managed, but it's just one of those things that it's good to have a bit of peripheral knowledge about.
Good question,
yes,
so
please.
If they came in without being on, but they fulfill those criteria, would you be game to be the one starting them on it and then still continue?
Not at all.
Delay surgery.
So this is definitely something I want to highlight because I want to have the knowledge of what a patient should be on, because then I can ask the cardiologist and the treating team why they aren't on it, and maybe they've got a HAS-bled score, a bleeding risk score that's very, 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 very high, in which case that makes complete sense. But at least I'm going to be thinking about why is this patient different to every other patient, and that's the reason for it. It's definitely not in my scope of practice to start something like that. And in a perioperative setting, if there's no determined date for surgery, I would definitely ask the question and start them on the appropriate anticoagulant for the AF. Good question. So your next patient in PAC is Melinda, 70-year-old, for total hip replacement. As she is getting her routine ECG done, the nurse comes in to ask for your advice.
So this is an appropriately calibrated ECG demonstrating sinus rhythm with a normal axis and a rate of approximately 70. That shows essentially normal T-wave morphology. The QRS complexes are on the large side of normal, but
good. I like that you've said everything looks pretty normal, and then the nurse says that suddenly the patient said they felt a bit abnormal, and this is a new ECG. What do you make of this?
Okay, so this is an ECG where there's a irregular rhythm on it, and it's got a left axis deviation. In terms of the rhythm, there appear to be some complexes which could be P waves. which are visible in the sort of leads V1 particularly. I think my differential here would be a wandering atrial pacemaker or atrial fibrillation.
Yeah, good. And so you determined that it is atrial fibrillation. Hey, just before I move on, I want you to read this ECG for me. It's unrelated, okay? Just, I actually like the way you read both ECGs, very systematically and everything. I just want to chuck this one here. Let's give it context. You're in PAC trying to deal with this nuanced AF, and the resident comes in and says, hey, please look at this ECG, I'm scared. I have not seen anything like this. What do you make of this, Dr. Blackman?
Sure. So we can go through the usual things of the ECG. I think the obvious abnormality here is that there are several different morphologies of QRS complex.
Yep.
In fact, there's several. I think there are two. It looks to be that there are these broad, complex, sort of ectopic complexes that follow on from T waves.
Mm-hmm.
This appears to be bigeminy.
Mm-hmm.
So that's the sort of first abnormality there. In terms of establishing the rhythm of the normal complexes, you can see that most of them appear to have a normal P wave proceeding.
Mm-hmm.
But if you look at the third QRS complex in the V5 rhythm strip, it looks like the P wave is inverted there.
Mm-hmm.
And the same for the 1, 2 complexes after that, 3 complexes after that. So it looks like there's either the P wave is buried within the previous ectopic, or there is some atrial conduction abnormality as well. So it looks like there is ventricular bigeminy, and either a sinus arrhythmia or an issue with P wave conduction.
Okay, so what I like what you did with that, Ben, is that you spoke of the kind of the obvious abnormality here, and the obvious abnormality is that there seems to be these ventricular ectopics or these complexes just scattered throughout, and without any context that could be meaningful or meaningless really. But then you went on to define the meaningful complex here. So the patient's normal complex. Hey, can you see my cursor? When I talk about this kind of ECG to people, I just want to take a step aside from the guidelines to talk about how to interpret really complex and weird ECGs. So a lot of the time when I ask someone how to interpret this ECG, they get bogged down in the ventricular complexes. Everything looks abnormal, everything looks bizarre, and that can be quite confronting. So I just want to make this as an example that when you have a crazy looking ECG, all you have to do at that point is make mention of the craziness, which is the multiple ventricular ectopics, but then straight off, ignore them. Go into the actual normal QRS complex, or the normal for the patient QRS complex, and then start describing them as you would any other thing. Describing it as best as you can with rate, rhythm, axis, hypertrophy, and describing the PI interval, the QRS complex, the ST segment, and the T wave. So go through your normal formula for describing an ECG on the QRS complexes that you can describe them about, and not getting bogged down with the ventricular ectopics. So I thought you did that really well, Ben. Cool. Moving back to your patient, now that you explained that away. She's had palpitations on and off for the last day. Ben, I'll stick with you. What do you do for this patient?
So this was a 70-year-old female for an elective orthopedic procedure?
Yeah, that's right. 70-year-old female, Melinda, total hip replacement, and that's all you know. And now she's had this this ECG, and she's reported having palpitations on and off for the last day.
Okay, so from a sort of cardiac surgery risk point of view, this isn't an emergency. Palpitations isn't necessarily an active cardiac condition for the sake of it, but because this is elective, I think we can safely say that with the new cardiac condition, it's very reasonable to refer to ensure that she's adequately worked up.
Yep.
So she'll need to have potentially Holter monitoring. She'll need to have some blood tests. She may need to have a form of rate or rhythm control, which isn't really within my scope of practice to prescribe.
Yep, great.
So I think that sending her back at least to her GP for ongoing investigation and management of the AF is very reasonable. If she's I suppose the first thing to say is to ensure that she's not actually unstable with the AF. I'm assuming it's just palpitation.
Yeah, beautiful. So
she's.
That's all right. So everything you said is right. This is new onset AF. You need to contact the right people to solve this problem. And cardiology is consultant, and they're actually pretty keen to go and sync defib the patient because it's recent onset. Assuming that's the right decision, and you decide to proceed, do you need anticoagulation for this?
I mean, that's a cardiology opinion, really. They may be willing to do a TOE to establish if there's a clot in the left atrial appendix before they start. Appendage, rather, before they start. I would question whether if she's in intermittent AF already, whether defibrillation is really the answer here. Given she's been describing it as on and off, and we've seen her go into it on and off. So I think I'd have a discussion with cardiology about whether it's the right decision. But in terms of her overall risk to undergo a cardioversion, there was nothing specifically mentioned that would stop me from anaesthetising for that.
Yeah, sounds good.
Decision.
How about anticoagulation? Obviously, it is a cardiology decision. What do you reckon? As far as my understanding of the guidelines show that you should have therapeutic INR or treatment with a DOAC for more than 2 weeks prior to cardioversion, or demonstrated absence of clot on a transesophageal echo. Yeah. And I like that you get a very real-world answer. I mean, first of all, I don't make this decision. Cardiology makes the decision. Just because a patient has had palpitations on and off reported for the last day, maybe it's actually gone on for a longer time, and maybe they are at risk of a clot. So again, a lot of this isn't up to your decision making, but just to be aware that anticoagulation for cardioversion for AF patients with AF of 48 hours duration or longer, or when the duration of AF is unknown, they need anticoagulation. Anticoagulation with warfarin INR 2 to 3, or factor 10A inhibitor, or another DOAC for 3 weeks before, and at least 4 weeks after cardioversion, regardless of the CHA2DS2-VASc score or the method used to restore sinus rhythm. You organise for an inpatient bed, and she's booked for cardioversion. As she leaves your clinic, she then suddenly collapses to the floor, conscious but feels lightheaded. What do you do? Does anyone want to have a go at just running through this scenario? So I'm going to, put a bit of crisis management into this presentation, and yeah, who's that?
I'll have a go just because I've been in this situation quite a few times.
Sounds good.
So initially she's collapsed to the floor, so you initiate your routine ALS assessment, so airway, breathing, circulation, see whether she's conscious, maintaining airway, and whether or not you need to start CPR. And then assuming you've done that, then if she's stable, and the blood pressure is okay and she's conscious, then yes.
Nicole, step through the ALS for me.
Do a sternal rub, see if she responds. Check the airway. Put her in the recovery position. See whether she's maintaining her airway, whether she's breathing, and then if she's not, then you call code blue and start CPR. You don't need to do a pulse check anymore. It's just whether or not they're conscious of maintaining their airway.
What I might do is, as you offer me questions, I will give you the answer to them, and that will help you. Can they proceed down? You check for response. She's talking to you fine.
Yeah.
She just collapsed. She's feeling lightheaded.
Check the airway.
Just to be specific, what's after?
She's talking.
What was that? Sorry.
So talking, airway, breathing,
So
circulation.
just with S, because you're in pre-admission clinic, you call a code blue because the patient doesn't have an inpatient bed or anything. They're talking, so the airway's patent. They're breathing normally, as you mentioned. So at that point, you check a respiratory rate, auscultate the lungs, get a SATS probe on. Everything is normal. Respiratory rate's normal. SATS of above. SATS are 96%. What's your next step?
Yeah. Circulation. So take blood pressure. Do a set of routine obs. And do.
I'm gonna get you to
ECG.
Instead of saying, I definitely just because this is what most of the time in our exam, you won't have to go into the detail of this. But in this particular lecture, I'm going to get you to go through the...
Oh, okay. So heart rate, blood pressure, oxygen saturations, respiratory rate, and temperature.
Beautiful. Temperature is 36, respiratory rate is 16, saturation is 96%. This is your heart rate, 160, blood pressure is 70 on 40. At this point, you're now in the recovery, area. So you've got lots of monitors, lots of people, lots of hands, all of your equipment that you normally have in recovery at your disposal, just to give you context. What next?
And I'm just confirming she's actually conscious.
Correct. She's still talking to you. You're talking to her.
If she's fully conscious and meditating, I would do an ECG quickly so I can see what rhythm it is, and then I would probably give amiodarone if she was conscious and follow the guidelines before I'd shock her, assuming she was maintaining a conscious state.
Yeah, that's right. So she is maintaining a conscious state. The ECG is exactly what you saw before, rapid AF but at a rate of 160. You give amiodarone. What dose do you give, and how do you give it?
So it's 5 milligrams per kilogram, although some protocols say just to give 300 milligrams.
What do you give?
And you give it venously, and depending on the response.
How fast do you give it?
Yeah, go.
How fast do you give it?
I'll just give it straight up, just over about 20 seconds in this scenario, because she has the potential to rapidly deteriorate and you want a relatively quick response. So I wouldn't give it as an infusion. I'd just give it over about 30 to 60 seconds.
Are you sure about that?
No, not 100%, but I've done it in the past and it's worked quite well doing it that way.
So I think most people would say if someone has arrested, you just give it as a push, straight up, as you say. But if they have a blood pressure of 70/40, I would definitely never give it that quickly because of the risk of severe hypertension being precipitated.
Fair enough. So you'd run it over like 5-10 minutes?
Yeah, I'd give it over 15 to half an hour. And I'd be cycling the blood pressure, pretty often because I've got it, or take invasive monitoring at this stage. So you do that. You don't get a change to the heart rate or the fact that she's out of rapid AF. What do you do next?
I would organise to do a synchronised shock.
Any other medications you could give?
You can give intravenous beta blockers, such as IV metoprolol or IV esmolol, but you do have to be a bit careful depending on what her other comorbidities are and what the situation is giving IV beta blockers. So if someone's septic, for example, you wouldn't go down that route.
So what I want you to do, Nicole, is I want you to make the assumption and just give me the answer. So the reason I asked you to do that is there's a concept in the exam called the registrar asks the question and the consultant makes the assumption. So you can either give an answer like saying something like, I could give a beta blocker depending on what they have and if they've got other problems like sepsis, but that's not happening. And you take a longer time to get to the answer that is satisfactory in most circumstances. So let's say you give a different answer, something like, look, assuming they don't have contraindications to a beta blocker such as COPD or asthma, which there's no sepsis in this situation. I wouldn't even bring that up. I would just say that I'm checking for other contraindications, and I would give a small dose of esmolol followed by metoprolol, something like that. That way you get to the point of what you're getting to, because I'm not going to try and chuck in something like, oh, this patient's suddenly in sepsis or suddenly in... If the examiner wants to give that to you, they can say, yep, sorry, you did check for COPD, they've got COPD, what do you do now? But you don't need to make too many questions, you can just keep moving with this. So what dose of beta blocker and what would you give?
So I would give, I'd go for metoprolol, so I'd give 1 milligram of metoprolol, and then I would wait 2 or 3 minutes to see the response, and then gradually keep giving 1 milligram boluses.
You correctly give those 1 milligram boluses up to 5 milligrams, but you're not really getting any response. And like you mentioned, in consultation with the other consultants there in cardiology, you decide to do a synchronized defib. I'm going to pick on someone else now. Who wants to tell me about synchronized defib in this patient?
Lahiri, do you mind if I just ask, in terms of the decision tree of drugs versus electricity?
Yes.
Am I right in thinking that essentially when you're doing your A2E, you're looking for 4 signs of decompensation being a systolic blood pressure less than 90, loss of consciousness, chest pain, or a respiratory decompensation from heart failure?
Yeah.
If any of those are the case, I think the ALS algorithm goes straight for shock rather than trying drugs. And clearly there are these grey area cases where you have somebody who has a blood pressure of exactly 90, and they're,
I would say
they're mentating, but
you're absolutely right. And I think, because I'm an anaesthetist, I would be giving aramine because I know that that's going to put up the blood pressure and decrease the heart rate. And while I'm getting stuff set up, I know that there's very little risk in me giving amiodarone slowly whilst I get things set up. So I completely agree with you. If you follow the guidelines, you'd be completely right in just saying this patient has signs of compromise. Sync defib is the very next step. So you're completely right to say that, and we'll go through that. I'm completely okay with someone doing, because what I know is real from the experience of seeing this is that you can completely get stuff set up ready for this while you do other things. So from a realistic anesthetic point of view, I'm definitely not going to pick on someone if they start with some medications, because their skills are so much better than the normal physician in terms of supporting this, and that's the only reason why I'm okay with that.
Also, Lahiri, sorry to interrupt. If you end up cardioverting the patient anyway, you have the ALS guidelines say to commence the amiodarone infusion over 10 to 20 minutes. So it's worth putting it up. It's going to take time to draw up and get it sorted, but while you're sorting the cardioversion out as well.
Fantastic, yeah. Parallel processing a few of these things it just adds a level of expertise and complexity to what they're trying to make a simplistic flowchart. So I completely agree with that. Good. Who would like to describe for me some sync defib?
Okay, so synchronized defibrillation is aimed at ensuring that the cardioverted defibrillation occurs on synced with the R wave. Mm-hmm. To aim rather to avoid unsynchronized RNT phenomenon and precipitation of a worsened tachyarrhythmia.
Sounds good.
You perform the same safety checks as for normal defibrillation, except for the C part of the coach algorithm, because you shouldn't be doing compressions. But the same safety features are present, such as oxygen away and everyone standing clear. And you charge to 100, 150, 200, whatever. There are specific recommendations for different types of tachyarrhythmias, but I would, if a cardiologist was there and had a strong preference for one, I would go with what they said. Otherwise, I'd just go 100, 150, 200 generally for my 3 attempts.
Do you know what the ALS guidelines suggest for AF, for sync defib?
I think 120.
Yeah, 120 to 150. And for other rhythms, I think it's 70 to 120. So it's funny, 120 is the magic number between. I've never seen anyone start on 120 for AF though. In our DCR list, it's always 150 and 200. Keep going.
Yep, and then you press the sync button.
Tell me before you go on to that, what's your setup? I want to just to give the context to the whole gamut of what you need to do to set this up. Can you run through what your setup for this would be, including pretty much everything?
Okay, so in a fully monitored patient with ECG monitoring saturation probe and 1-minute lead blood pressures, I'd have an anesthetic or airway trained person at the airway, and have a second medical staff member in charge of circulation and drugs, including sedation if required for a very conscious patient. In my hands would be fentanyl and midazolam at very low doses, as I don't want to precipitate any respiratory deterioration.
This patient is completely conscious. 70-year-old, 70-kilo patient. How much of what would you give for sedation?
I would give 25 mics of fentanyl and 0.5 to 1 milligrams of midazolam.
Mm-hmm. They're still very conscious on that. Would you give anything else?
Another 25 mics of fentanyl, anticipating pain associated with the DC cardioversion.
Sounds good. She's looking pretty good now. Keep going.
Yeah. And then proceed with the pads on the patient with a 3-lead ECG as well, attached to the defibrillator, and press the sync button. and go through the OCH and then do it.
And that's good. What's specific about pressing the button? You press the button?
You must press the button and hold it until the delivery of the shock.
Yeah, sounds good.
Because it's trying to time it with your sync.
Exactly. It's one of those things that, say the first time you do it in a while, you press it and you're like, oh, why didn't that work? And then you go, oh yeah, I didn't hold it down. Fantastic. That's good. That's good detail. This is the guideline from the Australian Resuscitation Council. Really amazing. I think it's just an amazing guideline. Obviously super busy, but I think it's just really easy to read once you know each of these sections: the unstable section, the broad section, the narrow complex section. But we won't go through a lot of the detail of that. What I like, Ben, previously, you mentioned the stable features. So any sign of instability, I just use the mnemonic HISS, HISS. It just helps me to remember them. Heart failure, signs of ischemia, syncope, or signs of shock. Anyway, let's move on to this. So, do you need to have the patient anticoagulated post return to sinus rhythm? And yes, so for patients with AF atrial flutter of more than 48 hours duration or unknown duration that requires an immediate cardioversion for hemodynamic instability, anticoagulation should be initiated as soon as possible and continue for at least 4 weeks after cardioversion unless contraindicated. Okay guys, she's having a bad day. After defib, she appears to have this rhythm. What is it? I want you all to make a decision on what this rhythm is. Take 10 seconds to do that. In fact, write it down so you know what you're saying. Okay, who wants to have a go at what this rhythm is?
Yes, I can say that.
Yep.
This is a complete heart block. By saying that there is a complete association between the P waves and wide QRS complex.
Hey BJ, so I found that this was actually quite tricky because I've obviously got these wide complexes, but the trick to this is that the wide complex, the wide complexes on the QRSs, they're not regular enough for it to be complete heart block. Like they're actually associated with each P wave. So there's actually Mobitz type 2, but I've just given you a tricky one. So just again, this is cardiology stuff. It's hard to appreciate what these are, but just the secret to this one is that the complexes of the QRS complexes aren't regular, and that's why it's Mobitz type 2. So you get P wave followed by QRS, P wave dropped, P wave QRS, P wave QRS, P wave dropped. So this one's
regular PR interval.
Yes, it is a regular PR interval. Mobitz type 2 secondary heart block. This one, however, yes, this is complete heart block. And so she deteriorates to this. Her heart rate's 35, the blood pressure's 70. What do you do? Who wants to have a go at this? She's having a bad day. Poor lady.
I'll have a go.
Go, James.
So, because Priya has been looking after this patient, she's already beautifully monitored. She already has all the emergency drugs drawn up.
Yep.
So we're in a good starting place. So this is complete heart block with hemodynamic instability. So our options are to treat pharmacologically or electrically.
What would you give?
So that would either be with repeated doses of 500 mics of atropine up to 3 milligrams, isoprenoline infusion starting at 5 mics per minute, or doing pacing. And the options with pacing, we've already got pads on her, so external pacing is very easy to initiate.
I'm going to ask you another question. So first of all, James, again, it's for everyone to notice a way that James is doing this is really important. You ask him for an answer and he gives you the whole story, so I don't really have to ask him anything further. So you can either say, I'd give atropine, and then the examiner says, how much? You said 500 mics. Then you go, what else? And then you got another 500. Or you can just say atropine 500 mics up to a max of 3 milligrams, followed by isoprenoline 5 mics. You can get the whole story of pharmaco treatment of bradycardia in a couple of seconds, and that's a really good exam technique. However, I'm going to ask him one more thing. What's another drug you can give before you start pacing?
Adrenaline?
Yep. What else?
glucagon.
Yeah, good. Because this patient's had a lot of beta blocker from the management previously.
For God's sake.
Ah.
Jesus, stop giving her beta blocker.
Don't blame Nicole, blame the algorithms. Good. Okay, so you give those to stabilize. What else? We've got through that. How much glucagon do you give?
It's actually quite a lot for a beta blocker kind of overdose, because doesn't it come in milligram vials?
It comes in a 1 milligram powder, which you can put 1 ml of sterile water from a separate injector into it. How do you give it? IV, IM? How much? Yeah, look, you can completely give it IV. And but let's get back to the external pacing. James, talk to me about external pacing. What am I doing?
So for external pacing, you need appropriate monitoring. So you need, because what you want to do, you need to be able to tell if you've got capture. Is the big, and you use the lowest energy possible. But you're going to need a sedated analgesed patient in order to do external pacing, because it's exceptionally uncomfortable. So sedation, I think probably judicious amounts of fentanyl, and probably midazolam, just because it's got a slightly longer duration, rather than having to keep titrating in bits of propofol while you sort out her pacing. And then, so it's still synchronized. You need the 3 leads on as well as the pads, and you start at low energies that I can't quite remember what they are.
Yeah, that's right. And often you can start at low or go up, or 10, 20 milliamps to 30, and get capture. Tell me about what is this concept of capture? What are we looking at?
So you're looking for a corresponding, it's electromechanical capture. So you're looking for the electrical stimulation to create a mechanical contraction. And there's different ways that you can do that. So you can either look for the pacing spike and a QRS complex to follow it. It shows you stimulated the heart. We can use a pulse oximeter to see that there is a corresponding pulse that comes with it, or you can palpate, or an arterial line would be another way to see that you've got a stimulating spike, electrical QRS to follow it, and then also a pulse.
Yeah, good. You've definitely got the right idea. Specifically, I turn on the pacer, fixed or demand. There's a really important little principle of pacers. Either you have a fixed rate, so very different to internal pacers. You either have fixed or demand. Demand is when it senses if there's electricity happening, and then it only gives an output if it needs to, or fixed means it's just going to deliver it. Now, I had the really unfortunate or fortunate experience of having to pace someone on the table when I was a registrar, and demand just didn't work. There's so much going on and so much interference that the default on the external pacer of having demand meant that it wasn't actually pacing, even though everyone thought it was pacing. So by turning it onto fixed meant that it was actually working. And think about what that means in real life. The surgeon was there with this very large patient having some kind of multi-level laminectomy. The patient had a bradycardic arrest, and because everyone was there in a hurry trying to do things, even when we got the pacer on, it was sensing interference, therefore it wasn't giving a rhythm. So in an emergency, maybe not in this particular situation, but in surgical emergencies with lots of interference, you definitely want it on fixed. You turn up the amps, just dial it up. You then get spikes, and that happens very early on, where you can see where the electricity is coming, being sensed and given by the pacing device. You then see electrical capture, so a pacer spike followed by a QRS complex. And then after that, you want to always check that there's a mechanical capture, that for every electrical QRS complex, that there's also a pulse waveform. So, finger on the pulse or SATS probe or outline, whatever it is, you need spikes, electrical capture, and mechanical capture, which you rightly said. Finally, you shouldn't just stick to the ampage that was adequate for this electromechanical capture. You want to go 10 above or so, just to give a little bit of leeway and bit of extra protection from that. Just in the chat.
The fixed and demand.
Yes.
If a patient has an intrinsic rhythm and sort of whatever 30 per minute, and you give them fixed pacing. Is there a possibility of R on T phenomenon there, or will it still be syncing?
To answer, there's always the possibility of something happening, but if you have a very slow intrinsic rate, you'll probably have the heart in the refractory period. So I think that's a very low danger of that happening. And if you're not getting an output, that's a far higher danger. You could always say, I would start with demand, and if there was no success with demand due to interference, I would then go to fixed, and that would maybe be a safer way of saying that. But I think you'd be very low risk. I'm not a cardiologist, so I have limited experience in that, but I'm just talking logically, I guess. But I could be wrong about that, so please check that.
Yeah, there. I was sort of wondering if there was a lot of interference and you were sort of, moving them and there was lots of bumps and stuff. Could you just go, more than 10 above the threshold in order to get that demand pacing?
The interference. Sorry.
You pace them above their natural rate.
Sorry, just before we go into that. So with the before we go into that, the amount of ampage above something will not reflect the demand or fixed. So demand is just it's a separate issue to driving 10 milliamps above. But yeah, Nicole is right. So I think what I'm doing there is I'm getting at a higher rate than the intrinsic rate. So it's a form of overdrive pacing. Someone just asked about what my abbreviations are. And I'll actually send you guys a document on my abbreviations and the structures that I have that have helped me, especially with the short answer questions for thoroughness. But I'll send that off to you guys in a while. And so this is the bradycardia algorithm. And again, I think we've covered that. I just wanted to give you a bit of a Viva style thing for that.
Lahiri,
yeah,
please. Question.
Please.
What sort of sedation or analgesia would you recommend in a conscious, externally paced patient?
Yeah, so I think we're very lucky that we're anaesthetists, that we can pretty much handle most airway compromised situations. In the DCR lists, I give midaz, fentanyl, so 50 of fentanyl for almost everyone. Almost everyone gets 2 of midaz, and that is very very forgiving, even in the oldest patients, and often they get a bit of propofol. That's the stable patients, elective DCRs. I think if someone's already blood pressure of 70, just giving midaz and just the fact that it's longer acting and has a very wide therapeutic range, just really helps.
What about sort of ongoing external pacing?
Ongoing external pacing. Look, I think, I reckon just with your clinical acumen, you'd be completely fine in whatever you did. For example, you could be just titrating midazolam and not having the cardiovascular problems of propofol, or you could run a low dose of propofol, 5-10 mils an hour, running aramine at the same time. I think anything you do will be fine, and I'm sure if you asked 100 anaesthetists, they'll give 100 different answers. Yeah.
Okay. Thanks.
Look, I thought we'd just go down this rabbit hole. So can you all make a statement about what this rhythm is? 5 seconds, write it down, make a call. Anyone can.
Type
2?
Yeah, right. So it is type 2. It's second degree heart block. Now, why is it that I can't tell if it's type 1 or type 2?
Can't see enough of it.
Exactly. I can't see enough of it because I don't have a PR interval to compare to another PR interval. So I don't know if there's going to be an extension. So this is what we call fixed ratio AV blocks. And they can be, 2-to-1, 3-to-1, 4-to-1. You just don't know. So fixed ratio blocks, secondary heart block with fixed ratio of P waves can come in all manner of ratios. And they can be a result of type 1 or type 2. I just wanted to chuck that in there because it's not something we talk about a lot. But I don't want anyone in the exam or in real life to get confused thinking that this is going to be an okay one. Like, I don't want you, it's far better that you call it type 2 and get cardiology and pacing ready than to call this type 1. The fact is you can't tell. There's some indicators that might give you a bit of an indication. So life in the fast lane goes into this, but type 2 is more likely to be broad, complex, and in the context of other problems like bundle branch block or bifascicular block. But this is not certain either. So observe the patient for a period of time, cardiac monitor, have a longer rhythm slip, and you can see maybe what happens to various PR intervals. So I just wanted to chuck that in there. Bit of a rabbit hole. Sorry about that, but I think it's really important because often we're at the pointy end of things when things are going really wrong, and I would hate to get this wrong and send someone to recovery or onto the ward thinking they were going to be okay. Also, we went through the perioperative cardiovascular evaluation. Every anaesthetist loves morning coffee. Went through some atrial fibrillation stuff and some tachy-brady management, just to recap. Now onto the valves, coronary artery disease and pacemakers. So, 7-year-old male, inguinal hernia repaired, loud ejection systolic murmur found as you auscultate the patient in the anesthetic bay, because some people still do that. Past history, hypertension, cholesterol, weighs 90 kilograms, and has some chronic renal impairment from the hypertension. Exercise tolerance is pretty good, walks 2 kilometers a day, can climb 1 flight of stairs to his apartment every time. What do you do in this situation?
So again, this patient's similar to the one we discussed earlier, where it's an elective procedure with someone who might have severe AS but who has a good exercise tolerance. I would, given this is a completely elective procedure, delay the patient for investigation unless there've been previous investigation.
Sounds good, they haven't. So you could say it could be an active cardiac condition, and for these purposes you do get an echo. The echo says the Vmax is 3.6, pressure gradient is 37. What is this category just based on that, Alex? What's the category of what's the severity of his aortic stenosis?
So I think that's moderate, based on pressure gradient.
Beautiful. And so this is the beautiful little guideline from the ACC AHA. And it's different from the previous guideline in the sense that they talk about, they talk less about the actual valve area and more about the pressure gradients. The valve areas, correct me if I'm wrong, but the valve areas are calculated from the pressure gradients, and maybe that's the reason why, but I don't know the detail of that. So in this case, this patient is not symptomatic, so they're in the in this category here, 37 millimeters mercury pressure gradient, asymptomatic, and so they wouldn't be suitable according to these guidelines as a type 2A recommendation because they're not having other cardiac surgery. What would it take if they're LVEF, if they're symptomatic with an LVEF of less than 50% and these other parameters? Then you could go ahead with an AVR in that situation. So as we just mentioned here, so AVR is recommended for symptomatic patients with severe high gradient AS who have symptoms by history on exercise testing. AVR is recommended for asymptomatic patients with severe AS and an LVEF of less than 50%, or indicated for severe AS when undergoing other cardiac surgery. So even if they're asymptomatic and having other cardiac surgery, it is a grade 1 recommendation, level 1 recommendation for having an AVR. So 5 years later, he's not doing so well. His AS is now seemingly severe. 75 years old now, elective lap chole for biliary colic. He has deteriorated, now with limited exercise tolerance and unable to do cleaning tasks. So just appreciate what this is. He's got recurrent biliary colic. Lap chole is required. He's deteriorated. He's also had a non-STEMI 2 years ago, and his renal impairment is now moderate. So this is now a severe symptomatic aortic stenosis. What's the chance of this patient dying with or having a major cardiac event in the next 12 months? I want you guys to, 5 seconds, just jot down a percentage number just to make a call on this. 5, 4, 3, 2, and 1. What do you reckon? Who's got a number?
10%.
What was that, sorry?
10%.
10%? It's actually 50% in the next year. So that's a really important thing to know, right? Like when you're making these decisions about what we should do about this patient, you're thinking lap chole is bad, but really, this having severe symptomatic aortic stenosis is about the highest risk operation you could have, really. So just appreciate that when we think about what we need to do moving on. So this formal echo shows signs of severity and a poorly functioning ventricle, so really not great. So what do you do? What operations should he be offered? I want you guys to now think of the gamut of what you could do for this patient. Take 30 seconds to think about that, and I'll ask someone
So obviously, ideally, we'll defer this surgery to optimise his cardiac conditions. In deciding, I'm interested to know the status of his ischemic heart disease and whether or not he has any remaining lesions that need intervention, and so that should be investigated preoperatively.
Absolutely.
In the options for his aortic valve on its own, we can have the minimally or less invasive and then open cardiac options. So we could offer him balloon aortic valvuloplasty, although that's not a good long-term option. It would just be a temporizing measure. We could offer him a TAVI or an aortic valve replacement, and those options would depend on his comorbidities and functional status.
Fantastic. And then what happens if his biliary colic started becoming worse? He was more of started getting into the biliary sepsis territory. What other procedure can this patient potentially have instead of elective chole or lap chole?
So this man, for managing biliary sepsis, could have less invasive options, and so one option may be an ERCP. How that is typically quite physiologically challenging in and of itself, and particularly its complications can be. The other option would be a cholecystostomy or a PTC.
Fantastic. So I've got here cholecystectomy, a TAVR under sedation or GA, and a surgical AVR. Fantastic. Again, just to know the gamut of things that you could do for a patient, I think is really useful. There's not, often we're dealing with not the most, complex situations, a whole number of people in the anesthetic and the surgical team, and I think it's really great to have a really broad overview of what is possible. Who wants to describe the TAVI procedure?
So a TAVI procedure is a endovascular procedure, usually through the femoral artery, to deploy a mechanical aortic valve in patients deemed unsuitable for surgical AVRs, although there are multiple trials looking at whether that can be broadly, more broad range of patients would qualify for TAVIs. The procedure itself is minimally painful, but it has certain requirements. The patient should have all standard anesthesia monitoring, including, and then in addition to that, an intra-arterial line, and ability to monitor the patient with transthoracic echo, usually, at the very least, and pads on. It's an off-the-floor procedure in a radiological, in a cath lab, basically. And it's usually done under sedation to minimize the impact of general anesthesia on the patient. There are particular critical points, such as when the valve is deployed, which requires the patient to be overdrive paced by the cardiologist to a tachyarrhythmia, so that the heart is virtually still to allow for optimum deployment. So major patient factors are an ability to lie flat and still through the procedure, really. If they can do that, you can do it with sedation. Okay,
so essentially, when you look at the figure here from the ACC AHA guidelines, essentially anything that satisfies an aortic valve replacement plus having a high surgical risk or prohibitive surgical risk is pretty much the patient group. So, this patient, based on the presumptive surgical risk, based on your own knowledge or the surgical team's knowledge, means that you might either go the surgical AVR route or the TAVR route. Okay, just went through that quickly, but I felt like that was the most important part of that, the one that probably comes up most in real life and in the exam. So, quick summary: we've gone through cardiovascular evaluation, AF, tachybrady, and valves. Okay, on to the 2016 guideline on the duration of dual antiplatelet therapy in patients with coronary artery disease. And just note that the Australian Society, so the Cardiac Society of Australia and New Zealand, used to come up with these guidelines. That the last guideline was back in 2009, and it's just surprising that they haven't come up with anything since then. So I think, like most things, most things cardiology, I think we just really always refer to the ACC AHA because that seems to be the guidelines that are most referred to in my experience. Okay, so our next patient is Ravi. He's having some heart issues like it's Groundhog Day. So he has stable ischemic heart disease, stable angina. They did an angio and decided to stent him. How long does he need to be on clopidogrel? So everyone just write down their answer in 5 seconds. And obviously it depends on what kind of stent, so please specify.
So I'm wondering if there's a difference with it being due to stable angina rather than due to an MI, but I think with the bare metal stent, it's 6 weeks, and with the drug-eluting stent, it's at least 6 months, preferably a year.
Yeah, good. So bare metal stent at least 1 month, and you're right. So they have separate guidelines and flowcharts for stable ischemic heart disease, or SIHD, as you'll see in the upcoming slides, versus an acute coronary syndrome and management. And then drug-eluting stent at least 6 months. So how about if Ravi then had a few episodes of melena over that time period? No management necessary post the scopes. There was nothing really to inject. It was just something that the patient was having based on the fact that they were on an antiplatelet. What can you do about the clopidogrel? So how much leeway do you have with this clopidogrel ideally? Obviously, this is a multidisciplinary decision that requires, definitely conversation about risks and benefits. But what do you reckon? How soon can you stop the clopidogrel in this circumstance?
At least the patient has to take 4 weeks of clopidogrel and need to wait until the 4 weeks. Once the 4 weeks is, then we can stop the clopidogrel and go for scopes.
Okay, so
At least it has to be there.
So in these guidelines here, so stable ischemic heart disease, they're having one of these stents. And so, if they have a bare metal stent, if there's no high risk of bleeding and no significant overt bleeding on dual antiplatelet, greater than 1 month may be reasonable. So you're right in that for the bare metal stent. So with drug-eluting stent, it's such a high risk over a longer period of time. What they talk about with these guidelines, and again, these are just class 2B recommendations. So, I'm sure your conversation with a cardiologist may change what occurs in this situation, but discontinuation after 3 months may be reasonable. And we're talking about high bleeding risk patients. Say they're getting, some kind of, severe bleed, such as melena or something like that, or they need to have some emergency surgery due to that previous thing I briefly mentioned, which is if Ravi needed a TERP due to severe urinary obstruction. Again, there's gray areas. Maybe they can put a catheter, maybe they can do other things, but this is the knowledge I feel like it's important to have a robust discussion with the various parties. So now just the next flowchart. I'm trying to make this culturally diverse because there's too many Jims and Bobs around. Unfortunately, Ravi's cousin Veena actually had an acute coronary syndrome. They decided she's for medical management. She's on dual antiplatelet therapy after this admission. 6 months later, she comes to see you about having her total knee replacement. What can you do? So when can you do it? Again, take 5-10 seconds, make a call.
I think the 2016 guideline states for ACS on medical therapy at least 12 months, I think, from memory.
Yeah, and is there any room to move on that?
I'm not sure, actually, not as far as I'm aware.
Yeah, that's right. And
I guess it depends if she's had other treatments like bare metal stents, drug-eluting stents, or.
Yeah, sorry, I didn't mention so she's not had she's just for medical management, so no stenting is done.
Yeah.
But essentially, any decision, stent or otherwise, is dependent on these 3 factors: risk of in-stent thrombosis, obviously, consequences of delayed surgical procedure. In this case, it's probably just pain, and there's degrees of that, and then increased intra and peri-procedural bleeding risk if the DAPT is continued. So the interesting questions that you could ask, or the advice that the guidelines do give, is that there's newer generation drug-eluting stents, and so maybe for selected patients, depending on the length of the stent, or stents at high-risk bifurcations and high-risk areas, or numbers of stents, depending on if that occurs or not, you might be able to have select patients on these newer gen stents only for 3 to 6 months of dual antiplatelets. Or maybe there's IV antiplatelet bridging therapy. Again, there's no convincing evidence for this, but maybe it's something you could talk to the cardiologist about. But also that data from more recent large studies suggest that the time frame of increased risk of stent thrombosis is on the order of 6 months, irrespective of the type of stent. So just a few things to think about. And again, you discuss it with cardiology, but hopefully having this knowledge helps you have the discussion. So patients treated with PCI undergoing elective non-cardiac surgery, these are roughly the time frame. So greater than 6 months since drug-eluting stent implantation, you can discontinue the dual antiplatelet therapy, and class 1 recommendation to then proceed with surgery.
Lahiri, where it says in that sort of above the yellow box, sort of delayed surgery risk greater than stent thrombosis risk. I mean, that's probably fairly arbitrary, is it? Or are there sort of numbers saying, if you've had STEMI at 1 month, this is your risk, 2 months, 3 months, you know, like, is that just kind of us going in our head, oh, well, yeah, they need the surgery, so...
Yeah,
or is there anything more scientific to it?
I don't know the answer to that, I got to say. I think at the end of this, I think what's most important is awareness that there's data out there, but then all the nuances and complexities are above that. And you know, I just know that this decision will not be something I make alone. The obvious stuff about talking with the cardiologist, but again, I think knowing this is probably useful, and that's why we're going through this. But yeah, I think it'll all be difficult decisions when we're at this side of the time frame of dual antiplatelets.
So this is for patients who've had a PCI for an event.
Yes, that's right.
If they're treated medically, do we go back to the other AHA guidelines and say 60 days?
Yeah, so this is these are two of them side by side. Stable ischemic heart disease, so not having an event. And again, I'll make this, these flow charts are available with those documents that I sent out. So, you know, have a look and compare to see that they're, you know, are very slightly different, but have a lot of commonalities. But again, good to know that these are the guidelines that are available there. I think what you've particularly asked me then is a recent acute coronary syndrome, you know, non-CX or STEMI. Depending on what they have, there's these recommendations for, you know, even if it's just medical therapy, to still try to continue 12 months of clopidogrel. And then there's a class 2B recommendation for discontinuation at 6 months. Okay. I found reading those guidelines actually quite confusing, and you know, I think there's so many situations and so many subtleties to it that I'm just going to accept the guidelines for what they are. That there's, you know, a rule of thumb that I can use to help make decisions, as I mentioned. But again, I think we all realize that this will be up to, you know, managing this in consultation with appropriate consent and with cardiology, and knowing that any surgery is going to have such a varying range of urgency and other operations that could mitigate risks or make risk lower.
I know we're right. I don't want to take up too much time or anything, but
no,
I
you're
just
good.
wanted to, like, I guess this, because I thought the same thing when I was trying to understand this part. It's so confusing because there's so many different colors and graphs, and you see so many different months and time frames.
Yes.
But from what my understanding is, it looks like ideally, if you weren't having surgery, you're going to end up on clopidogrel for 12 months if you've had a CAGS or you've had some sort of drug-eluting stent, right? But if you need surgery, we'll let you have that surgery after 6 months, unless you need the surgery really urgently, in which case you have to weigh up the risk of in-stent thrombosis against the risk of delaying surgery, and there are risk factors for both of those things that you can assess, and then we might let you have the surgery after 3 months. So I think, like, that's how I've tried to summarize it simply, because otherwise it gets really confusing. Is that an accurate summary?
I think that's actually brilliant. I'm going to actually add that to my slide for the next time. I think that's great. So I'm sure everyone heard that. I think it's a really good summary to just say ideally 12 months, if not even longer. 6 months if you need surgery, and most surgeries that are elective can be, you know, with help for 6 months after. And if you really need it before, 3 months with advice and balancing risk. I think that's a really great summary, Priya. Yeah, I completely agree. So interestingly, this next one, practice advisory on the perioperative management of patients with cardiac implantable electronic devices, so pacemaker and implantable cardioverter defibrillators. So this is, you know, released this year, 2020. So I thought it was really useful to go through this. And again, I'll try to, so this is our last section. Yep, I've got you guys for another half an hour. I thought we'll try to go through this again as much like a Vive or as practically as possible. So 60-year-old for an emergency thoracotomy. Let's say it's an esophageal perforation. It's pretty urgent. These patients deteriorate really rapidly. Had an AMI 10 years ago, so not the best specimen. while you're doing an assessment, you notice a pacemaker scar and device on the left chest, but the patient doesn't really know too much about what's going on. So, what do? I want you guys to take a minute and just talk out loud what you do. Again, I want you guys to get talking, get very comfortable saying your thoughts. What are you worried about? What do you need to do? What information do you need to gather? Go for it. Take a minute. Specifically get to the point of what do you want to know about this pacemaker? And write that down. Write an exhaustive list of what you want to know about the pacemaker. Okay, good. On the pacemaker check, what information would you like?
So the main things from a pacemaker check, you want to know the type of pacemaker, you want to know thresholds of the leads, and ideally you want to know specifically to the type of pacemaker it is, if the patient is pacemaker dependent,
yep,
and if it's a combined pacemaker and defibrillator.
How do you know if he's pacemaker dependent? Because there's not something that says pacemaker dependent on the form. What are you looking for?
So it's, I can't remember what it comes up as.
It mentions a percentage being paced, A or V, yeah. And I make an interpretation of that. If they're using it 90% of the time, I'm like, well, this may be pacemaker dependent. That's not always right, because they might be paced at a higher rate, meaning that they'll fall back. Say if they're paced at 70, they might have an intrinsic rate at 60, in which case it's not really that dependent, but it'll give me an indication of dependency. Why did you want to know the thresholds?
Just because that'd be quite useful information. You might be able to see deterioration over time.
Okay. Yep. I actually didn't know. I never looked at that threshold, so that's useful to know.
It's left over from when I did cardiac. For some reason, I just look at it.
Fair enough. It's never changed my management, but I'll look at it now and see what happens. Why do you want a chest X-ray?
So if you know nothing, a chest X-ray, you can tell if it's single or dual chamber in terms of leads. You will also be able to see if it was a defibrillator as well.
Fantastic. I want to point out that that's a really important fact. So look, this is everything I want to know about a pacemaker in general. If I had an ideal situation, I'll obviously, this will be on the slides, the link that I give you, but you can take a photo of that if you'd like. Yeah, so essentially the advisory does recommend this stuff, so kind of obvious things there. But say this patient can't give any information. So yeah, patient's confused, no previous medical records. You're absolutely right. If you simply go towards that chest X-ray, you can get a lot of information. So, the fact that you can actually look, I've tried this and I haven't had much luck on some of the chest X-rays that I've seen, but apparently you can actually see the type of pacemaker and the brand, and that's often what you need to get an emergency help from St. Jude's or Medtronic or whatever it is. But like you mentioned, James, you can see the coil as well. So if you have a defib, you'll have these thicker coils to know that this patient might have an AICD. Again, that's not absolutely certain. I've seen some X-rays where it doesn't look that thick, the coils don't look that thick, but I think that's a good general rule, and that really helps me to delineate whether I need to definitely put a magnet on to stop the patient getting an inadvertent cardioversion, or to proceed in another way. So I thought that was really useful as a recommendation from this very guideline as well. Yep, so that's a couple of images just to show what leads look like with a normal pacer, and then what the coils look like in an AICD. Again, when I first looked at the guidelines of this, the older guidelines, that just blew my mind. So hopefully it does so for you too. How to check if they're pacing dependent. So if I had nothing there really, I could really just turn on activate pacing detection on the monitor, and if there's consistent pacing spikes, then great, I've got to be a bit more wary of this patient. Just note that our modern monitors are all pacemaker detected on automatically, but that some of the older ones, you have to go into the ECG advanced settings and turn it on. So you can't be guaranteed that they're going to have pacemaker detection on automatically. Good. So sources of EMI, electrosurgery, radiofrequency ablation. So a lot of obvious stuff here, but I thought I'd get down to the pointy end of things. So the advisory goes through a lot of recommendations. And look, I've got to say, pretty much the summary of the advisory, actually, can someone tell, is someone familiar with this document? And even if you're not, you can probably tell me right now what their general guidelines, their captain obvious statements are going to be for all of these things. Who wants to have a go at that? I know there's putting someone on the spot, but there's some obvious things that you can go through. And instead of, if I was to tell you the guidelines and tell you to remember stuff, I think that will take a lot of space in your memory that's unnecessary, because the guidelines are actually really obvious in what the expert consensus recommends. Who wants to have a go just telling me roughly what they think they say?
You can have a try.
Go for it.
So for a pacemaker, you obviously want to ensure that the patient maintains the cardiac output. So electromagnetic interference can essentially cause issues with pacemaker detection and can essentially cause a pacemaker to not deliver appropriate pacing, and therefore you can have a duration of time when the patient doesn't have the cardiac output due to electromagnetic interference. So for this reason, you might need to turn the pacemaker off and externally pace.
Yep. And what are the recommendations for each of these things? You know, what should we do about diathermy?
Oh, sorry, I think I misunderstood the question. So in terms of the things you need to worry about with electromagnetic interference is going to be being close to the pacemaker. So, you know, below the sort of the umbilicus, you're probably not too worried about most things. You want to do it for a short period of time, minimize if possible, use alternative things if possible. So if you can use a harmonic or something, then that's going to be better than diathermy.
Yep.
If you can use bipolar diathermy rather than monopolar, that's going to be better.
Yep.
So clearly it's going to depend on the type of surgery you're doing, but you know, something like a thoracotomy or, you know, surgery on the thyroid or that kind of thing, it's going to be very difficult to avoid using diathermy in proximity to the device.
Hey, so Ben, you're absolutely right. So the captain obvious of things that you should do is exactly what you said, and it's the same for everything where it makes sense for it to be the same for. So, you know, minimizing diathermy. They talk about infrequent or minimizing the use, keeping it far away from the generator, the pacemaker generator itself, and using bipolar or harmonics, and you know, avoiding monopolar if you can. So all of these, whatever it is, roughly talks about these principles. Often the statement is there's limited evidence, but the consultants and ASA members strongly agree with that stuff that you've just said. So that's really the repetitive manner by which this guideline expresses some very reasonable things. So that's great. It's actually really not hard to remember what the guidelines are. The only extra thing for MRI is sometimes you have an MRI safe device or an MRI unsafe device, and the only change there is you'd want to turn it onto MRI safe. You want to turn it onto MRI safe and or reprogram and then reinterrogate afterwards. Same with the ECT as well. So it's pretty much saying limit EMI, keep it away from the EMI, reprogram from the MRI for MRI and ECT, and then reinterrogate after MRI and ECT. So that's a summary, and it's actually quite easy to remember. Okay, so back to our friend over here with the emergency thoracotomy. The surgeon said, you've said everything that you've said to try and make sure that this potential pacemaker AICD is going to be okay. Let's say that it is a pacemaker and AICD. The surgeon needs to use frequent monopolar for the case. It's a thoracotomy. It's obviously that's going to be the So what do? Do you guys have a method of how you would manage this situation? I want you to take 2 minutes and just speak out your thoughts of how you would get through this case.
I'll have a go here.
Go.
So are we saying it's a pacemaker or an AICD, or are we sort of talking about both?
Let's say it's both. Yeah.
Okay. So if monopolar diathermy is unavoidable, you would want to place the return plate such that the current doesn't ideally so that the current doesn't pass through the pacemaker.
And let's say that's not possible really, like, you know, your diathermy is going to be very close to where the generator is anyway, so it's going to be very difficult to avoid EMI in this case.
So with an ICD, the risk is that the device interprets the electromagnetic interference as a shockable rhythm and delivers a shock, which you obviously want to avoid. So therefore you would be using a magnet to avoid that. By using a magnet, the ICD is therefore not operating. And therefore you need to be very vigilant with your ECG monitoring to ensure that the patient doesn't go into a malignant arrhythmia.
Great.
In which case you would need to shock you would need to remove, shock them yourself, or just remove the magnet.
Mm-hmm. And how would you shock them yourself?
Say again, sorry?
How would you shock them yourself?
So you would have placed defib pads on preoperatively.
Yep.
At least 8 centimeters away from the device.
Mm-hmm. Yeah. Now, have you ever tried to shock someone with an open chest?
No.
Yeah, and what's the, if you imagine, like, I'm not saying that you can't, but imagine what could happen with an open chest. What is the potential problem of shocking with external pads?
I guess sort of burns, or you've got potentially blood around.
Yeah, and also because it's open, there's so much impedance, there's air now, there's so much space between your chest wall and the heart that you may have just nothing occurring. No current is actually going to traverse because of the heart now high impedance. So what could you do then to get ready for this? If the external pads aren't, I'd definitely put external pads on if I could, but if I can't do that, or if I can, but I'm worried that it's not going to actually work, what else do I need to get ready?
Transvenous pacing.
Yeah, I mean, that's pacing, but not shock.
You've got an ICD there. Would you not just take the magnet off?
Yeah, you could do that.
You've already got excellent pacing in situ.
Yep, absolutely, maybe. I've had a situation where someone's arrested with an AICD, but because the rate, it was VT at a certain rate, the AICD was programmed at a higher rate to give a shock. So there we were waiting for the AICD to shock, but the subtlety was that it was not at the right rate for a shock. There's no guarantees with anything, so I'm just getting to a point where you can be even more certain about whether, if you need a shock, you will shock. Have you heard of the internal pacing pads? Yeah, so the little paddles you attach to the same defibrillator. They use it in cardiac surgery, and they're internal pace and they're internal defibrillation pads. They just look like these spatulas that you put across the heart. Yeah, so you know, I'd get that ready in this worst case scenario. Keep going. That's good.
So that sort of, I suppose, answers the question about the AICD part of things. Regarding the pacemaker, you would, I mean, as part of this case anyway, you'd have an arterial line and ECG monitoring.
Great.
And again, being vigilant to ensure sort of ongoing cardiac output. If the electromagnetic interference was being interpreted as intrinsic cardiac rhythm, then the pacemaker may not pace, and you may either lose a beat or several beats, or you may become hypotensive. And in that case, you would have to ask the surgeons to stop. Ensure that you get return of electrical activity and cardiac output.
Absolutely. You're in real close consultation with them, and
again, I suppose.
So good. I've got pads on to external pacing defib, internal pads ready, magnet on, ECG with pacing detection. I need an output monitor, and like you said, you're in close contact with the surgeon because you know anything and everything can go wrong if this person is very reliant. Again, I'm painting the worst possible picture, and I'm preparing for that because this is you know what we do. We try to prepare for the absolute worst, and we've already sorted out in our heads in a hypothetical fashion. Good, and then post-op obviously monitor with pads on, check and reprogram with a technician as required. This was definitely an example of just giving you the worst case scenario, and it's a concept of just exploring the worst hypothetical, because by doing that you already plan for you know what could possibly go wrong. Really helps you in real life, helps you in the Viva as well. Yeah, that's really great, Joe, thanks. This is a little algorithm based on the Alfred Heart Center. That kind of simplifies a lot of the management plan. So is there EMI or diathermy? If there's no changes necessary. If yes, do the ECG with pacemaker detect? Is the patient paced? And then you know the tricky area is if yes, is the underlying rhythm? And if yes, you need to do the following things: pacemaker, no changes, AICD, put a magnet on. If there is an underlying rhythm, you need to convert the pacemaker to asynchronous mode, and again with the AICD, put a magnet on. So that's a really just simple flow chart. And I'm sure we've probably got a Western Health flow chart as well. It's worth referring to. Hey guys, thank you so much for your time. That's all for this shoot. So yeah, any questions before we go on?
Hero, if the pacemaker, if we're doing a left thoracotomy, there's no real option to use a magnet in that scenario. So therefore, you would aim to turn off the defibrillator with the tech and have pads on for like pre-opening of a pre-incision, and then turn it back on straight away afterwards, right? And then you would use internal defibrillation during the case.
Yeah, and I'm trying to think of the situation where there's no tech available. You know, it's a rush to theatre situation. But you're right. So if there's a tech, turn it off. You know, reprogram to asynchronous mode. But without a tech available, in the worst, unlikely bad position, what would you do with that? And as you can see, like, there's really no good answers. There's just a whole lot of, you know, risks that I have to manage. And I don't think anyone has the right answer to that, whether you just somehow get a sterile magnet, which is definitely possible, or something else.
Okay.
Yeah. Thanks, guys.
One other thing I wanted to add here was when I was at the Boston, we had a couple of pacemaker interrogators in ED.
Oh, lovely. Yep.
So you could run down and grab it and bring it back up, and if it was in daylight hours, just be on the phone to the tech, and they could guide you through interrogating it yourself.
Okay.
Send you a report within a couple of minutes, which I thought was quite handy.
Oh, that's pretty handy. Yeah. Often the cardiology registrar is always on call. They know the systems and what needs to happen. So that's always useful for whichever hospital you're in. Yeah, good one. Definitely fill out your feedback forms. Let me know if there's anything else you'd like added or different structure to this. And any questions, just email me. And if I got something, you know, if there's something you wanted to clarify or even challenge, please let me know. That's all good. Thank you so much, guys. You have a good rest of your day.